Hi, I'm Katie Simon. I'm a leadership team member of National Survivors Union, the United States National Drug Users Union, and its representative in the Substance Use Data Collaborative. And I'm calling in from Holyoke, which is on the unceded lands of many Algonquin tribes. Today, the Substance Use Data Collaborative is continuing our multi-part Confronting the Drug War Roundtable series, in which we host activists who use drugs and harm reduction researchers to discuss drug policy reformation, structural inequities in drug treatment and harm reduction systems, deconstruction of the disease model of addiction, and alternate ways to think about drug use. This series is sponsored by the Yale Program in Addiction Medicine, National Survivors Union, the UCLA Center for Social Medicine, the Drug Policy Alliance, and Program D35 at EHES. This is the second part of a three-part mini-series within the larger series on synthetics in the drug supply. This session is entitled When Synthetics, and we'll be discussing how synthetics emerged in the drug supply in various communities, exacerbated existing injustices, and how communities have responded. I'm joined today by Alex Collins, Ed Chapman, and back by popular demand, Louise Vincent. And yeah, if you all don't mind going around and sharing your name, pronouns, your affiliations, and some of your journey in and your motivators for this work. Alex, if you don't mind going first.
Yeah, thanks so much. So my name is Alex Collins, she, her pronouns. I'm currently an assistant professor at Brown University based in Rhode Island. Before coming here in early 2020, I had lived and worked in Vancouver's downtown east side since about 2015 or so. So I really kind of moved from the housing and HIV space into kind of the intersections of these as it related to drug use and really kind of seeing the shift in the drug supply between 2015 and 2016 really unfolding in Vancouver and kind of what that meant. So I really I come from working very closely with harm reduction organizations here in Rhode Island and also Vancouver. I come as an ally, not as someone with lived experience. So I'm appreciative to share this space with you all today.
Yeah, Louise, do you mind going next?
Sure. Well, my name is Louise Vincent, and I am with the National Survivors Union. I'm also the executive director of North Carolina Survivors Union. I come with lived and living experience, and I have she, her pronouns. Yeah, I have worked in harm reduction for a couple of decades, it feels like, and it really has given me a place to speak, find community, and really live. So I'm more than a harm reductionist. I'm a drug user organizer, and this is my life.
Ed, do you mind taking it from there?
Hi.
You want me to just...
Hi, I'm Dr. Edwin Chapman. I'm in Washington, D.C. I've practiced addiction medicine for the past 25 years. For the past 20 years, 19 or 20 years, I've had a private practice in opioid use disorder using primarily buprenorphine.
And look, what's that? A wild harm reduction activist of years. Nick, would you like to introduce yourself as well?
Yeah, wow. Sorry, you guys. I was having a mad hard time trying to find the panelist thing here. My name is Nick Boyles. I'm a leadership circle on the National Survivors Union, and really happy to be here. I do a lot of work locally and nationally. Here with these fine people, Louise and Katie. I'm happy to be here.
Awesome, thanks. So I will take it to the first question. So how did synthetics emerge in the drug supply in your community or context? And what were the initial consequences you experienced from the shift. Nick, if you can go first, and then Louise, and then Ed, and then Alex. Nick, I know you're always a wealth of information on shifting drug trends in Indiana, and specifically in Bloomington, where Indiana Recovery Alliance is based. So I'm really looking forward to hearing your answer on this.
Yeah, sorry, I should have said I'm also the executive director of Indiana Recovery Alliance here in Bloomington, Indiana. Yeah, we watched it kind of come in. It was funny. I had been not, using for a while and went back to use, and this weird dope hit me really hard, and I didn't, this is some years ago, and I didn't realize, I just felt it was like a stronger version. They called it China White. Funny enough, when it first showed up here, they were calling it China White. Yeah, yeah, I know. And it was odd. The high was so weird. It was like quick and then gone, quick and then gone, and like you'd have to do seven. It was like shooting coke, But watching the skiing of that, which was probably 2009, 6, 7, 8, 9, something in that area, to now, we've just seen it get a switch from where it was added to a little heroin, and then fully focusing into, there is nothing in the state of Indiana that has heroin. Nothing. We have not seen anything checked, nothing. I think we get our drugs. We're such a small like enclave. We don't have any ports. We're landlocked, so everything comes via Indianapolis, and then via other states bringing their supply in. And just recently, we've seen stuff like xylazine creeping up in huge amounts. You know what I mean? So like we have these horrible xylazine testing strips, which I'm not a big proponent of, but they're showing positive for absolutely almost every sample test. The ones that we're hoping for FTIR checking here. Legally, it's really hard. We have a very conservative state, but like, just the funniest thing I had happen yesterday just about this. It was ironic that a participant was talking about loving xylazine dope, and I was like, yeah, I was like, what do you mean? He's like, I don't want anything but xylazine. And it really boggled my mind. And I really kind of think we did a disservice when that article came out about calling xylazine an opioid, or acting as an opioid, because a lot of people just see that verbatim as truth. Well, a doctor said it means that. It's not actually an opiate. It acts as an opiate on a different receptor, from what I understand. And it seems like people have taken that to heart, and like, this person now just wants that dope. And that's where things get really scary. They don't understand what damage it does, even though I put out tons of information. So like, definitely the swing has been that way, Katie, and it's been into a point where in our state we're cracking down on fentanyl. We have death by distribution here. It's heavy duty. Me and Louise have talked about this numerous times, that like the next step will be they'll crack down on fentanyl, and we'll have like nitrazines, or we'll have the next research chemical, which will not act the same, which will cause cognitive functions. Yeah. So I'm just waiting for that unfortunate shoe to drop, and hoping to be prepared for it to take care of my people both nationally and locally.
Thank you so much, Nick. And you're referring to the preliminary work from Nabarun Dasgupta's team at UNC Chapel Hill, stating that xylazine acts as a kappa opioid, which,
Right.
if anyone has the link in the chat so people could take a look at that themselves, I'd appreciate that. Louise, speaking of xylazine, I know you were one of the first to ring the alarm bells in early COVID about the emergence of xylazine in North Carolina. If you don't mind talking about that, and just about, the emergence of synthetics in North Carolina, I'd love to hear about it.
Yeah, we got an early batch of xylazine, I think, somehow. Um, and I was using, at the time, I was moving between methadone and buprenorphine, and unable to make that jump. And I didn't know what I was using. We didn't have an FTIR at the time. Um, and it has some positive effects if you don't know the negative effects, right? It lasts a little longer than it makes the hold time longer on fentanyl, so you don't it's not so short. And it was pretty strong. And so we watched this come in, and I reported on it, when it first, I think Don found it first on the FTIR that was given to us by Nan Golden. And and we reported about it. We studied it. We found it in Puerto Rico. We started studying the dope in our city. It was in some of the supply. You know, now we had a drug testing and checking machine, but what we were also finding was, you know, 12 and 13 things in the drug supply. So it wasn't, I mean, like you said, very rarely is there heroin, but there's fentanyl, and then there's, you know, 4 other things, and then 2 other things, and then, you know, it became ridiculous to see the lists, you know, and it was taking forever for Don to run the tests because there was so many different drugs in the drug supply. And this was a real, you know, this was a real concern when we really started the push back toward methadone. And we started seeing the wounds that come from xylazine and the real awful stuff that is connected with xylazine. So it emerged, you know, kind of like pretty fast for us because we saw it first. So we were trying to warn, but you know, like all things, people don't listen well. And when there's any positive effect, right, they're going to see the positive effect before they see the negative effect usually. And so that's what we were seeing.
Ed, I'd love to hear about your perspective as a buprenorphine provider in the context of this shifting drug supply.
So I've been again involved in drug treatment since the year 2000, initially with methadone. In 2005, I started office-based buprenorphine, but we didn't see synthetics in the Washington D.C. drug supply until about 2015, and suddenly we had about 20% fentanyl in our drug supply. So we had only 83 overdose deaths due to opioids in 2014, but that jumped to about 131 in 2015. By 2016, our drug supply had 65% fentanyl. In the next year, 75%. And since 2019, our drug supply has been over 91% fentanyl. So last year, 2023, it was reported by the medical examiner in overdose deaths to be 96%. We started also seeing xylazine, at least I started seeing xylazine and testing for it last year. So I have about 35 patients now that currently test positive for both fentanyl and xylazine. A number of our patients are now smoking rather than shooting. So I've yet to see any injection source, but it seems that smoking has overtaken injection drug use.
Thank you so much. I didn't actually know that about TC in terms of the shift in the route of administration. Alex, as a qualitative researcher with a really intersectional analysis, one of whose research interests is this shifting drug supply, I'd love to hear your take on this as well.
Yeah, I mean, I think Rhode Island, it's teeny tiny, but has kind of consistently been pretty significantly impacted with synthetics. Really, you know, we started seeing fentanyl here locally, kind of 2009, 2010, and have just had a steady growth since. So really kind of the big spike on our continuing upward trajectory has really been since kind of 2013, 2014. And now, you know, for the last, since COVID, we've had around, you know, anywhere from 72 to 78% of fatal overdoses be fentanyl involved. So really similar to kind of what Nick was mentioning, it's completely overtaken the heroin supply. I mean, we have a little bit of heroin that we've tested. A lot of it has been purchased on the internet. So, but much of the local supply is definitely adulterated with fentanyl. And then we've seen kind of an emergence of other synthetics as well. So xylazine, we started seeing this kind of 2021, 2022, we were testing for it. Also designer benzos, we've tested a couple of nitazines and some synthetic cannabinoids. So really, I think to, you know, similar to Louise, as we started testing the supply, we are testing on a really kind of comprehensive mass spec and LC-Q-TOF, which is really sensitive and specific, but we're seeing, you know, it's very rare to see anything with 1, 2, 3 kind of components. It's really upwards of 12. We have some samples that have more than 20 different cuts in it. And so it's so complex, and it's, you know, we haven't been tracking it at the state level and that kind of depth. So, you know, who knows how long xylozine's been here, but I think when we've asked people, we haven't seen the same kind of uh experiences that, you know, kind of up the 95 corridor some other places have. You know, we have seen some folks talk about wounds, but a lot of them are kind of the shift of, I'm getting really, really high, but so sick. And so I think it's, you know, people really kind of highlighting that, like, there is something different here. A lot of kind of early on, people are calling it like a new fentanyl. You know, there's this new thing, we don't know what it is. You know, I feel super high. And some people were saying, you know, felt like just on an intense sleep aid. So a lot of kind of more of those kind of physiological effects, not a ton around, you know, wounds. It's kind of, I think, shifted a bit since we've started tracking xylazine, but it's definitely, it's a shit show. It's so complex, and just changing constantly here.
Yeah, absolutely.
I'd like to add, like, one of the things that when we were talking about these different shifting stuff, and Louise was talking about all these chemicals added in, just lately, we had somebody send some stuff out of here to another place because we don't have any drug checking and it's kind of hard to do. And it came back with a psychedelic methamphetamine. So I checked it out. Yeah, I checked it out and I found some in Vancouver and a bunch of other places. And apparently, like, I mean, I don't know if you understand meth psychosis, but Jesus Christ, we have methamphetamine that now has a psychedelic stimulant, you know, psychedelic factor in it. That's just nuts, you know? So I just wanted to add that.
Thanks, Nick, for that. I think it's really important to also discuss how the stimulant drug supply is changing, even as because of, you know, with the focus on the overdose crisis, people often hyper focus on the opioid supply, even as we see, you know, that so many opioid overdoses are concomitant, you know, stimulant overdoses as well these days. So the second question is, um, I'd love for you all to tell me about who was most impacted by the emergence of synthetics in your context. What were the race and gender dynamics around how the new drug supply affected people? And how has the shift to synthetics interacted with pronounced racial disparities right now around whom is most affected by overdose? And any other intersectional analysis here is welcome as well. I'll start with Alex here. I know your research has investigated how housing insecurity, particularly eviction, has shaped how people manage and navigate the shifting drug supply. So I would, it would be great to hear you elaborate on that.
Yeah, I mean, I think, like, you know, with the emergence of synthetics in Vancouver, in particular, I mean, a lot of this was kind of hitting at the same time as mass evictions of people who use drugs from single room occupancy hotels predominantly. So we had these converging crises of, you know, really epic proportions that they're still really intense. And I think, you know, I focused and worked a lot with women. And what does that mean when now there's, you know, you're on the street, there's this new really kind of intense supply, really potent fentanyl, and people really needing to be able to kind of stay awake. I think it was shifting the amount people were using, where people were using, how people were using, and just the need to be able to kind of manage these new environments. And I think, like, we're seeing the same thing in Rhode Island. We have a housing crisis here as well. Encampments getting, you know, moved, people shifted and pushed out of spaces that where people are there to be able to respond in encampments, and they're getting pushed further and further out. And I think it's really, we're seeing kind of this shift for a lot of people using crystal meth, you know, needing to stay awake, needing to really kind of keep themselves safe from these uncertainties. And I think here, you know, we're seeing xylazine. It's always alongside fentanyl, but it's not just in the fentanyl supply. It's predominantly in dope, but we've tested it. It's in stimulant samples. We found it in some MDMA samples as well. And I think really to your point, Katie, we focus so much on fentanyl and take this really myopic view. And now we're taking it with xylazine, that we're overlooking the complexity of drug use and that people use polysubstances. And so a lot of our folks here, a lot of Black and Hispanic communities in Rhode Island are continuing to be disproportionately impacted by fatal overdose rates. And I think like last year, maybe 50% of fatal overdoses also contained cocaine. So we're really seeing this kind of mix of who's being impacted, but it's just increasing racial disparities, and that's overlapping with housing instability and, you know, racialized policing practices and these harsh penalties, you know, of scheduling xylazine, really cracking down on these kind of same practices of stopping the drug war, which we know is just reinforcing racial inequity. So I think that's really, you know, a big thing that we're seeing here, and it's really impacting different communities in such different ways. So it's it's really been quite problematic in terms of who has support and who are we focusing on in our messaging at the state level, and really sharing, you know, harm reduction messaging. It's still really focused, unfortunately, on opioids versus the supply more broadly.
Edwin, sorry. I know you've spoken in the past about opioid disorder treatment as an example of medical apartheid and even a eugenics model when it comes to treatment in the Black community. Can you talk about that a little bit in the context of synthetics in the drug supply?
Yeah, so the District of Columbia is 45%, 46% African American. 85% of our overdose deaths are among African Americans. About 74% are male. And we noticed since 2015 a significant increase in overdoses among the homeless. So, and that, of course, exacerbated by the post-COVID cutback in federal support for housing as well as Medicaid. So a lot of our patients who are on Medicaid now have to be recertified. And those gaps obviously put one at risk even for a short time, because if you're in treatment and then suddenly you can't get access to medications, you're back on the street, and your tolerance may be totally different. So we've again seen a marked uptick really in overdoses post-COVID. And overall, we've had a 600% increase since 2014. So that combination of social determinants of health plus lack of access to medication because of our private healthcare system. The fact that if you don't have healthcare coverage, you will not be able to get buprenorphine. In the District of Columbia, generally you can get Medicaid. You can get treatment for methadone, I'm sorry, without having insurance. But to get buprenorphine, you have to have medical coverage. So we have all of these factors, these social factors compounding our skewed insurance system, and the fact that that puts most of our patients in jeopardy because of these changing environments.
Thank you, Edwin. I think we, as harm reductionists, don't talk enough about broader health equity around insurance in the United States, and the fact that our healthcare system is broken as a whole. So how much more so is addiction medicine broken in terms of how stigmatized the patients are there? Louise, would you mind addressing how the changing drug supply pronounced affected, sorry, racial disparities, who was most affected in general by the shifting drug supply in your area, and any other race or gender dynamics or any other sort of intersectional analysis that you can bring to the issue?
Sure. I mean, we had started working with people using polysubstances uh, prior to most of the country, um, just because we're National Survivors Union. We know that people use more than one drug. That fentanyl is not the only drug, and opiates aren't the only drug. And especially with the onset of xylazine. You can cook xylazine up in crack cocaine and smoke it. So there's different ways that you can ingest these drugs that you can't ingest other drugs, and all of that has power and meaning. What we did see is we saw more smokers coming in, we saw more cocaine users coming in, um, and we've always had a lot of women too, because it's a women's sort of runs. It's not on purpose, but we have a lot of women working at our center, and people of color. We're working hard to address the racial disparities there. I think you know, uh, uh, we've done okay. I think starting out as a syringe service program doesn't help, right? Like we need to start these programs out addressing drugs and drug user health hubs, because when you start out as a syringe service program, right, you're saying that you have to use syringes to come here, and that is not always the case. And certain drugs use syringes more than others, and there's this is what we lack. Drug user cultural competency is what we lack. We don't seem to understand how drug users act and behave in their communities, and we don't seem to want to learn. We want drug users to learn how to behave in our community, or however you would say that. Um, we want it to be the other way around. But if we don't begin to learn the behavior that the people that we're serving are acting in and using in, then we are never going to be able to meet their needs. We know that. This has been long studied, this is not anything new, but we seem to forget it a lot. And especially with this divide between opiate and other drugs. I think there's lots of there's divides within the drug community too that need to be taken. People that use this drug, and so they don't talk, they don't work with these people that use this drug. So there's hierarchies within this, within the drug user supply chain too. So it's complicated, and I would like to see more drug user cultural competency. I've been saying that for a while. Like we need to understand drug users' behavior on a better level. We don't seem to understand, because we don't understand the drug seller, drug user difference either. Like most people that sell drugs use drugs. Most people that use drugs sell drugs. This same sort of ideas that people can't grasp hold of because they don't understand how the world works in that for that section of people. I hope that answered it a
Yeah,
little bit.
no, that was great. And thanks, Louise. Like, I know that this is kind of 101 for possibly the majority of our audience, but I don't think that it can be stated enough that the syringe service program model is designed for white, able-bodied, cis male participants. And until we address that national harm reduction racial equity gap, we're never going to get anywhere. Nick, would you like to talk a little bit too about racial disparities in terms of responses to the shifting drug supply, race and gender dynamics in general, in terms of who was most affected, and any other intersectional analysis you can bring to bear on the issue?
Yeah, sure. Unfortunately, I'm in a state that does racial relations just about as bad as any other state could. It's ridiculous. I mean, literally, like our population is probably 2%, 3% African American. If you take the college out, we're Mayberry with a college. You know, the odd thing is the syringe service program, like, or just the IRA in general, ended up being a hub for us. It ended up being a place where we could connect with other people who are kind of in similar movements. It's taken a long time and a lot of work because you're right, Katie. Intrinsically, these programs are set up for white males. I don't say just cis males. I mean, I think that because people associate us with the HIV epidemic a lot, and people wrongly correlate that to other things, that I just think it's just made to serve white people. I think a lot of our systems are made to serve white people. I think not. I once had someone talk to me when I was complaining about not talking about drug users enough in a place that said, "You mean we're not talking about white? We're not talking about white drug users." And that's the thing, is that's what we talk about. We don't talk about black drug users a lot. I think that I don't know the answers to that, or I don't know. I wouldn't deign to ever think that I have the ability to speak on that. I just think that, like, the idea of us taking these people and saying this is what drug use is about is ridiculous. Like, just what Edwin just said. Look at DC, 85%, and that's you're almost 46%, right? Make That's ridiculous. I mean, the statistics don't really lie, and I think that it's a common thing that you hear people talk about. Oh, the war on drugs is affecting the black community more than the white community. Like, that's not just partly real. That's like on a hugely systemic level. It is ruined. I mean, that's what it was created for. And I think if we don't, like, at the beginning of all these conversations, spit that to the loud seats, saying we're not, I can't talk about the drug user, black drug user perspective. I can't talk about a black drug user, but black drug dealer perspective, which is like, has almost nothing to do with actual drug dealing. It's survival because of a system we created. Well, I did, but you know what I mean, white people created. So I would let Edwin speak on that far more than me, but that's just generally, we try to do our best and approach it with best and hope that, like, we're doing a good job.
Go ahead, Edwin.
Yeah. So what really makes the epidemic so different in the African American community is most of our patients did not get medications from the doctor's office or hospital. They started with street drugs, and they were self-medicating because of what I call toxic stress, or the pair of aces, so to speak. And if you really don't know a person's childhood history or connect that to the environmental history, you really can't treat the whole person. So most of our patients have suffered for years in the African American community. Of course, it's been 400 years of apartheid, and that's what we're dealing with. So when we started seeing fentanyl in our drug supply, it was really heroin to fentanyl, and that transition was very rapid. And I think if we look across the country, we'll see the same pattern in other urban populations where there are a lot of African American patients. And that's why the overdose rate in the African American community has increased and now surpassed the white community. The other thing we noted was that our surviving patients, remember, we have two groups of patients. We have those that died on the street and those that actually made it to the doctor's office. So these were older. Here in the District of Columbia in 2015, the average age of my patients was 52. The average age now is 60. So many of these patients never overdose, even with fentanyl. When they come to the office, I have patients who test positive for fentanyl and xylazine week in and week out, in spite of the fact that they're on buprenorphine. So you could say that they're not taking their buprenorphine, but they're also not. They're also surviving with all of these chronic diseases older than 60. So what does that tell you? It tells you that we have patient populations that can metabolize these drugs at different rates. And now that we have injectable buprenorphine, we know that there are different doses of those injectables, which again tells us that our patients, because of liver metabolism, uh, uh, actually use these drugs at different rates. So the irony of this is that fentanyl and buprenorphine both go through the 3A4 system in cytochrome P450 system in the liver. And we found that our patients do better with higher than recommended doses of buprenorphine, which generally are capped at 16 to 24 milligrams.
Yes.
One of the things that we've shown, and I have a map that actually shows that in California, you can use up to 48 milligrams of sublingual buprenorphine. In Tennessee, it's 16 milligrams. In Pennsylvania, 16 milligrams. So what happens if you need higher doses of medication and you're in the wrong state? It means that you're really out of luck. So there's no standard of care, even for buprenorphine dosing, if you can get it across the country. And that's a travesty.
Oh, could I say something, Katie? Edwin, that is so on time. Like the methadone and buprenorphine provide protective factors. We don't, you knew how to say it in a medical term, whatever system, but they absolutely provide protective factors for people that use drugs. And what we see in the methadone system, at least in North Carolina, is a reducing of the dose. So they're starting people on less, refusing to move people up if they're on other medications. And this is really the system that I got caught in, and I see other people get caught in. I couldn't get my dose up high enough to make the shift to buprenorphine, and then I couldn't come back to methadone and get my dose up high enough to be on methadone. And so that resulted in someone that was pretty stable being destabilized completely. And I think, you can look and say, well, there's other stuff going on. Well, the main thing going on was a lack of interest and discussion around what the needs of the community really are. And so I appreciate you saying that and having the evidence to show it, because, we're starting people on 10 milligrams of methadone and 20 milligrams of methadone, refusing to move them past 40. It took 6 months, and maybe more than 6 months. It might have been a year for me to get a dose all the way up to 90. And that's just not, I used to say to people when I'd take them in the methadone clinic, I'd say, give me a week, give me 1 week, maybe 2, and your life is going to be a lot better. Just give me 2 weeks. And we could actually pull that off. That's no longer the case. And it takes a lot longer, and doctors are scared to prescribe, or they don't know, or I don't see how they could miss all of these learning opportunities, but they don't seem to be catching the drift that it provides a protective factor.
So you're absolutely right. We always talk about a blocking dose for these medications. Remember, buprenorphine has the highest affinity for the mu receptors. And if you start buprenorphine before a patient, let's say, waits about 12 hours till the other exogenous opioids are out of their system, it'll actually put you in withdrawal.
Yes.
So we now know that buprenorphine can even act like Narcan. So if you have somebody that's overdosing on fentanyl and you give them buprenorphine, it'll actually push the fentanyl off of the receptor site and really act like Narcan. It'll cause a precipitated withdrawal, and actually, because it's a partial agonist, does not have the respiratory depression that that fentanyl has. The other thing is the methadone guidelines were just changed in starting April 1st. So now you can start patients on 50 milligrams of methadone, where before, by federal guidelines, you could only you could not give a person over 30 milligrams starting dose. So a lot of, and you can now get take home right away with methadone. So a lot of those rules have been changed, but
Yes.
they're slow.
Nick, go ahead.
Yeah, I'm so glad those we fought hard to get those changed, and I hope it's in some small part to what we did. But the problem with all of these things, it doesn't filter down. So, like for me at my state, we don't even adopt the opioid. We don't even adopt the guidelines. Our state has said no. We're going to keep you at 2 weeks, and you have 2 years to get 2 weeks. And it's again my biggest problem with our current state. When did it become a thing where the law enforcement is over what doctors say, right? So like this is what boggles my mind. You know, to me in my world growing up, the doctor was the end result. The doctor was the guy you went to who could trump everything. He could take the president out of office. He could do everything, you know, because he had this specific knowledge. We're watching it with pain patients. We're watching it with everyone. We're systematically, the doctor is now the subject in a witch hunt. You know, and it's like I don't know what to do, but like Angel Kalani needs to burn in hell, and we need to figure out a way to get around this particular issue of putting doctors back into place. Like I don't know what happened when we suddenly someone hit somebody on the head and we realized doctors weren't effective anymore. So I'm like, it's just madness to me, and I wonder, I don't know how it affects you. Like I don't want to dove off into a subject, but like I think at the core of all this, had we listened to medical advice, we would be in a different place, you know?
Edwin, did you want to respond to that briefly?
Yes, that's absolutely one of the battles that we're fighting. We actually had a 4-hour symposium on December 11th with NIDA, the FDA, and SAMHSA to discuss buprenorphine dosing and the fact that we know that higher doses work better of buprenorphine and methadone because of these high potency synthetics. So getting state legislators, and many times the decisions are being made by bureaucrats and not physicians. After that meeting, we've presented that data to the district health department, and we've yet to have a meeting to remove prior authorizations for buprenorphine. One of the top educators from the American Society of Addiction Medicine, Dr. Edwin Salwitz, had a talk about a year and a half ago, stating the same thing, that we're actually seeing breakthroughs with these synthetics with patients who are on up to 200 milligrams of methadone and 24 milligrams of buprenorphine. Most of my patients, my surviving patients who do very well, are on 24 milligrams and above, up to 32 milligrams of buprenorphine.
Thanks. So we covered a lot of ground there, but I just want to underline one point. I think that, in the context of this deadly and shifting drug supply, we already have some of the tools. We have medication with evidence bases that span decades that we can use that give people this incredible protective factor that Louise was talking about. And yet, we still have methadone dose ceilings in 2024, even post SAMHSA's final rule. We still have buprenorphine providers that aren't willing to take advantage of telehealth. We still have, only a limited number of prescribers, even with the Xing of the X waiver. So we are really behind, especially with these interlocking systems of federal restrictions, state restrictions, and then just programmatic policy, which really limit our ability to give patients these medications based on best practices. So I will move to the next question. So how does the new drug supply, as well as responses to it, amplify injustices in your community or context? And I know we've already covered a lot of this, but I will give this to Alex first.
Yeah, I mean, I think, it's more of the same in so many ways where we really are seeing kind of this reinforcement of rhetoric that is, very xenophobic, very much focused on reinforcing criminalization, using very stigmatizing and kind of discriminatory language, especially around xylazine, that I think discourages folks from seeking care. There's this concern about going into a clinic and, presenting with a wound and needing support, and what's that response going to be? And so I think locally, we've also seen policymakers leverage drug surveillance testing that we're doing and try to frame that as, this is data to criminalize people. We need to actually be scheduling xylazine. And so I think it will just continue to drive the disparities we're already seeing. It will continue to really harm and reinforce, I think, the war on drugs and kind of target communities of color and really reinforce kind of the racialized policing that we're seeing. And that will just also drive overdose once folks are released from carceral settings. So I think we're just seeing more of that here. And I think we're seeing it broadly in the United States with, we're in one of the most complex drug supplies, and yet we have SSPs being targeted, and we have, recriminalization of drugs in Oregon. We have all of this regression when we have, Katie, to your point, we know what works, we know what can work, and yet we continue to choose to do the opposite of that. And I think, at some point we have to, there has to be something different. Like, it's just more and more people are dying, and more people are really being harmed. And I think frontline outreach workers and providers are so burnt out and so exhausted from trying to care for folks in overlapping public health crises where there's no light at the end of the tunnel, is what we've seen here. And so I just think these injustices are across communities, and also the people supporting folks who use drugs in the community. And just the community itself can't take but so much more. It's already it's exhausting for people. And so I think that's what I've seen here and heard here, is just people they don't have much more to give. And so we have to have this kind of continued push for more kind of evidence-based approaches, not criminalization approaches.
Edwin, please go ahead.
Yes. So I frequently use a model patterned after Michael Porter's so-called 5 forces. And you really have to look at this model to understand that there are multiple entities involved, and they use lobbyists to push their point. So if you are an investor in the jails and you have a contract for food services and jumpsuits, then you're really not interested in best outcomes. You're interested in filling those sales so that you make money. The same thing with the insurance companies who push back on higher doses of buprenorphine, which is singularly focused rather than looking at the big picture that you're actually saving money in the general population if you get that patient on the right dose of medication. I actually have patients who, one of my first patients on buprenorphine that I've treated for 19 years, got him when he was 57. He hasn't been back to jail or the hospital. He's now 77. So you multiply $100,000 times 20 years, and that's how much money we've actually saved by treating one patient. So we really have to understand that there are many forces at play in our community that are not focused on health outcomes. They're focused on their bottom line based on their perspective. And that's what has happened with the fact that we don't have national health insurance and that we don't have universal free access like Portugal and France to these medications. It should be free. Nobody should have to pay that drives the cost. That means that there would no longer be any street value for methadone or buprenorphine because it's free. Everybody should have access to it, but it also has to be put in the hands of capable providers who really understand dosing and what they're doing.
Thank you for mentioning how behind we are in terms of international models that really work, Edwin. I remember guest dosing in Paris some months ago when my plane was late, and it was like I was in an alternate dimension, where healthcare was actually delivered more equitably. Um, I just want to ask Louise as well, how does the new drug supply as well as responses to it amplify injustices in your community? Louise?
Oh, you're on mute.
Thank you. I was just going right for it. The new drug supply, amplifies all the injustices. I mean, everything negative that you've got, you just throw a whole bunch more negative on top. I mean, it was already bad. I mean, things weren't good as they were, right? So now you add, we didn't have a handle on the drug supply as it was. We weren't doing a terribly great job at that. And now we've added all these new factors. And what I see is people haven't changed their education tools, enough. People haven't, I mean, we've got to give people current information that's useful at the time. It's like when we saw, and we saw this really early on when we saw the shorts being used in the syringe service program, right? Like we were saying, I don't know what's going on, but we're seeing shorts. And that was a sign of fentanyl. That was a sign that people were injecting fentanyl. You had to use less, of the drug. And so there was a reason for it. So when you see these changes and when you see these changes in your programs, or you notice, something different, put a little funding toward it, write a grant toward it, do something, to explore it, or call a researcher or call somebody, and share the information that you're seeing, because we were writing about it well before other people were ordering shorts. It used to be that everybody just got 27 longs and that was it. And so the injustices just continue. I mean, as somebody could say, well, it doesn't matter, they got a syringe. Oh, it matters a lot. The kind of syringe you use and the kind of syringe you get given have a lot to do with, your vein health and all of those things. So you can really protect people, and you can really provide people better care if you're listening to them. I mean, I wouldn't think I'd need to say that, but it seems I do. So I'm going to go say it. You know, we need to be vocal. We need to be taught as service providers and service receivers that we need to ask for what we need. And then people need to try to get us what we do need, and then we need to educate, and we need, I would like to see, you know, better education around buprenorphine and the final rule and all of that stuff. We fought for it, so we know about it, but nobody else. There's not a whole lot of groups in Greensboro that know what's going on, or in North Carolina for that matter. I mean, there's just a few. But I'll always say this, and it's coming. I have a theory that in these smaller places, rural places where you don't have as much organized crime, so you have disorganized crime. And I think disorganized crime is really quite worse, because anybody can become a drug seller, and then you don't have anybody protecting the population or looking after the supply or doing. It's disorganized, and disorganized is what it is. It can be genius at times, but it also can be really a big junky mess. And I mean that with no slur attached to it. um uh we just really need to watch what we are doing. We need to listen, and the injustices, just, I mean, with the crime rates going higher, and what we're doing with drug sellers versus drug users, like, that's absolutely absurd. You know, the way we're putting people of color in prison, and now women in prison, women of color in prison. You know, we are. I mean, this is what we heard for a little while during the pill, you know, the quote unquote pill crisis or whatever. Um, they would say things like, we're not going to arrest our way out of this thing. Well, I haven't heard that in a while. What I've actually been hearing is, we're going to arrest our way out of this thing. You know, we're back to that kind of chatter. And that seems to be the only answer our politicians know to give to drug, you know, anything around drugs, like just tough on crime, tough on people, 3 strikes you're out, all of this kind of stuff that doesn't serve people, and certainly people with a disability, and people with you know, illness. You know, it doesn't serve poor people, it doesn't serve anyone well. I mean, this is just another this is just more of the same. And I think an exaggeration of the same. Like, now it's even worse. So I don't think it's gotten better at all. I think it's actually getting much worse.
Edwin, I'm gonna come back to you to tag on to Louise's comment in just a moment, if that's okay. Louise, I just want to underline what you just said. I think the 27 gauge model is really ill-considered, and comes back again to this problem of SSPs being created for white men. I once had a collaborative grant writing participant at my local organization just succinctly say, you know, 27 gauge syringes are for dudes.
Yeah.
Nick, before I let Edwin comment on Louise's comment, could you just talk a little bit about how the new drug supply as well as responses to it amplify injustices in your community?
I mean, one of the things me and Louise have also talked a lot about is, you know, in my community, the whole idea about there not being a hierarchical, either organized crime or whatever. Like, people throw anything in the dough. Like, literally, people will cut it with anything. Then you have these guys that change color from dough. If you're asking about how this is reflected in justice, I think it's made stark what we always knew. You know, I think it's made just more prolific the idea that we're living in a world that we have a government and a group of people who have not much care that we all die out. You know, who don't seem to show much in the way of. I mean, there are things we've shut down our economy for. There's, you know, we have this thing that's going on that we actually have the tools now, and now we've been studying it. Like, used to be able to say, oh, we don't know, we'd have to study drug use among populations, and we'd have to see all this. Now we have all this data. We know what works. Unfortunately, as it seems to be, like, there is so much money and so much power invested in this system. You know, it's a hard thing. It's really disheartening. I had no idea how much money was being funneled to keep racism alive and well in the world. You know, like, I mean, this drug war, we know what it's about. Like, we don't have to leave that an unsaid thing, you know? It affects white communities, but we know what this is a tool of. We understand this. So it's either there's two things. And this is what I just last final say about any of this, the whole thing with our government laws. Either we have the dumbest group of people on the face of the planet, right? That just have no fucking clue. None at all. They just go home and don't know what the fuck they're doing. Or it's fucking intentional. So which one do you want to take? I mean, Occam's razor, that shit. It's intentional. You know, so the point is, fentanyl put this fine line on things. It's funny. I think they put a fine line on shit they wanted to keep a little secret. They were just killing black and brown people in the corner and trying not to get looked at. Now that shit's in their fucking face. And it's like, what do you do? We have so much data now that you're doing this intentionally. What do you say now? And I just hope eventually that we figure out a way to change the power dynamic, change the outlook of it. But to me, that's what this has done. As it's exposed a group of people that might, I mean, I think kind of overplayed a hand. I hope.
Edwin, I'm sorry, go ahead.
Yeah, so I think Louise and Nick both hit the nail on the head. That from a organizational structural standpoint, from a business standpoint, scattering homeless encampments, uh, implementing drug-free zones where you just move people from one corner to the next are absolutely senseless. There are programs called by the acronym LED, Law Enforcement Assisted Diversion, where instead of taking somebody to jail, you take them to a treatment center. Uh, how how much simpler can that be to pick somebody up, but don't leave them on the street because you know that they're sick. But that's exactly what we're doing. So if we were to implement those types of programs, we would then be able to identify people who needed treatment, get them into the proper place, and start treatment. But that's not what we're doing, and what that actually does, it reinforces those who say that, oh, we need more police to solve the problem. Uh, uh, and so it really feeds into a certain dynamic, a certain economic dynamic as to where you stand in terms of the money scheme. If if having more police on the street is your goal, then that's going to be the outcome rather than spending more money on treatment. I think if you contrast the District of Columbia with Los Angeles, where the mayor, Karen Bass, has actually built housing and personally taken people off the street. And then she said that they need to be in housing for at least a year and a half in order to stabilize their mental health and substance abuse needs, supported by social workers and peer support. That's the model we should be looking at. That there's hope. Really looking at what Karen Bass has done in Los Angeles, as opposed to scattering the homeless. And she actually said that it's inhumane to leave people on the street untreated.
Thank you, Edwin. I would just like to add a note that, different diversion models are more or less helpful or harmful than others. I know that the original Seattle lead model is completely voluntary from what I understand, but in other diversion models, sometimes the programmatic requirements lead to people defaulting to going to jail in the end anyways, and spending more time in the system than they would have otherwise if they just immediately plea bargained out. Louise, were you raising your hand earlier or? Okay.
I did,
okay.
but I was just going to comment that I have seen some of these. You just have to be careful with all of these models that you don't end up with different coat, different hat, same person. Sort of. And there is some lead that I've seen be really good, and then some lead that it reverts back to the officer making the distinction about who gets to go to the program. And so I think you have to be really careful, especially in places like the South, that you have oversight on programs like that to make sure that they don't have the same people making the ultimate decision about who gets the program and who doesn't get the program. So I just want to offer that up, as we can't just, these programs are different in different places, work better in some places than others, and they have the same potential to become the same people going down the same pipelines if you're not careful. So I really think we need to use those programs and have better oversight on top of them to make sure that we're not creating the same systemic racism that we've had prior.
Absolutely. And my general thinking is to default to whether a community of directly impacted people desire diversion programs in their area or not. And I'm going to move to the last question. But before I do that, I'm just going to ask one specific question for Alex. How do the presence of the synthetics, as well as responses to them, change the conditions of sex work, both the policing and criminalization of sex work and the sex worker client relationship? I know that this has been a research interest of yours, and I'd love to hear you talk about that.
Yeah, I mean, I think we saw this quite differently in how it has played out in Vancouver compared to Rhode Island. I think here a lot of the sex worker groups that I have worked with, really opioids and dope aren't kind of a thing. It's mostly around stimulants. But in Vancouver, it was a lot different, especially as fentanyl became more and more kind of overtaking the supply. I think it created a lot of additional caretaking roles that sex workers had to engage in with clients. So around overdose response, around, this additional form of labor that's uncompensated, that is also has a lot of implications for legal pieces. So, yeah, we had the Good Sam law, but what does that mean? First responders are typically, or first people on the scene were typically police. And so what does that mean for folks who already are facing kind of this uh, asynchronous form, not asynchronous, asymmetrical form of criminalization around sex work? And then now you have an overdose, and now you're having to make these really tough decisions in the moment. So we were seeing a lot of kind of these shifts in forms of care that sex workers were having to engage in. But I think just kind of broadly, there is this additional burden that often kind of intersects with gender power dynamics and kind of gender forms of labor that are really taking over in terms of just overdose response broadly. It's definitely been heightened by the presence of synthetics, and would suspect is going to get kind of more and more complex with the changing supply now as well.
Thank you for underlining that particular aspect of uncompensated care labor. As a sex worker and a sex workers' rights activist, I've always talked about, this aspect of the work in which we are meant to act as tour guides for middle-class people's, slumming excursions into vice. And the kind of danger and criminalization that we face as criminalized people, taking care of inexperienced people who use drugs, kind of underscores the difference between being a criminalized person and a person who sometimes partakes in criminalized activity. Given that, I'd like to just move to the last question really quickly. I know we have a lot of questions in the Q&A. And the next session of our series will focus on this question. So really briefly, I'd like us to go around and each of you tell us about community initiatives addressing synthetics in your context, maybe share some community-driven solutions and ways of navigating the new drug supply, and what we can learn from them about what can be done and how effective strategies can be tailored to specific communities. Let's see, Nick, would you like to start?
Yep. So for us, it's drug checking, drug checking, drug checking, drug checking, drug checking. So there are some people in our state who are using, I don't know the real name, so pardon my French, are using shit sniffers to go into the sewage pipes and find out like if there's extra naloxone or extra fentanyl. Even though you almost generally every state's sewer system is so messed up that like it could be a clog in one neighborhood, and then all of a sudden the clog goes through, and that thing records like epic overdose rates by like a whole bunch of naloxone use, some shit like that. They're also trying to test syringes randomly, so like just every random syringe they pick up syringe test it. None of these work. So I am definitely like working my hardest and fastest to get FTIR drug checking by ACDC and the same people who always work, so we all are on the same page, and getting this like pattern to show our drug use to make sure that we can like find some kind of way around it. Somebody once told me that the government had a problem with us doing FTIR because they thought it was quality control. And at this point, I'm kind of like, great. I don't see the difference, like it's dying control to me, And I think that until, at least for us, as soon as I get that piece of the puzzle, I will do probably what NCSU is doing and talk to drug dealers. We talk to a bunch of drug dealers here, but where I'm at, they do not want to talk right now. It is too much. Like even weed dealers are getting busted here. So it's like I would be hurting my community more than helping them right now by even having these conversations. But eventually, hopefully, I'd like to do this. But mostly right now, it's just FTIR all the time, drug checking. What can we do? How? You know?
Edwin, I'd love to hear your take on community responses in DC, specifically around how addiction medicine providers are collaborating with their patients in response to these new threats.
So again, one of our major problems is the fragmentation of the treatment system. The way money has been expended in terms of grants without having different programs connected. For instance, harm reduction connected to treatment programs, connected to community-based programs, particularly in the African American community, the faith community, which has the strongest base historically. So if you look at that as if you were dealing with Native Americans and tribal culture, we also have tribal culture within the African American community. So we actually started with the faith community, building a base initially focused on the AIDS epidemic. Again, a stigmatized population. And once we found those faith institutions that were willing to address this, we were able to gradually progress to talk about relationship between AIDS and perhaps injection drug use. So now we actually have a core group of faith institutions in Washington that are willing to address returning citizens and the relationship with drug use and returning citizens perhaps are on medication-assisted treatment. So we have to connect all of these dots. So we've actually built a model with peer support specialists, people with lived experience who either used drugs or been to jail, et cetera, as the outreach component. And we want to present that model to the city as a unified approach, connecting all of these with experts in treatment that actually understand dosing, how to, that you don't put patients out because they're testing positive for illicit substances, that it's a process, and that you really have to get the confidence and the trust of the patient. So that's really what we're trying to do. We're trying to build what I call a community-centric approach to treatment, as opposed to individual patient-centered recovery. If you look up Dr. Gabor Mate, he talks about community-centric approaches to medical care. He's one of the finest internists in the world, who's written books on this and the fact that our culture created the problem, so our culture has to solve the problem. And if we don't accept these problems as part of our culture, then we're not going to get anywhere. So we're part of the problem. And I think it's no better stated than in Les Miserables by Victor Hugo, that if you create the sin or the darkness, that it's not the sinner who is wrong. It's the person or the culture that created the darkness. So we have to remove this have and have not divide in our culture, and that's where problem really lies.
Thank you, Edwin. What a delightful tapestry of references. I didn't think I would be hearing about Victor Hugo and Gabor Mate in the same paragraph today. Um, Louise, can you just talk briefly about community responses and community-driven solutions to navigating the new drug supply in North Carolina? You are muted.
There we go. I think Nick really got it for me. Drug testing, drug checking. We also, I'm on the get my milkshake ready for me. That was our drug tester, our resident drug tester and checker. So really drug testing, drug checking, safe supply, if that would be an option. I mean, methadone, buprenorphine, the protective factors we talked about that are there. We need to see better stimulant and other drugs be added into these sort of collection of tools. They for a while they were looking at different drugs you could take to help with cocaine use. I don't know, but I would like to see some medication assisted treatment attached to that. But I think for the main part, drug testing, drug checking, and really getting that information out to every part of the community and looking at the difference between, I mean, I'm really onto this like rural, urban kind of organized crime, like, and maybe rural areas needing some extra attention because of the disorganization. I really think this plays a really big part in small communities, where there's just little control.
Yeah, because organized crime at least has that financial incentive to take care of its customer base. I think that's like a really important comment, also kind of piggybacking on Edwin's really astute brass tacks economic analysis of, these problematic systems kind of exacerbating each other throughout this session. Alex, so could you just talk a little bit about community responses and community-driven solutions in your area?
Yeah, I mean, I think we have been pretty fortunate in Rhode Island to have somewhat of a more progressive response. We have a lot of kind of peer-led programming. A couple years ago, we were able to pass overdose prevention center legislation. So really all of this has been driven by our community activists, and really, it's been a labor of love, but one that's, I think, really, a bit delayed, but not because of the efforts of anything but, bureaucratic red tape. So I think that's been a huge kind of piece, really, as we started seeing this kind of presence of xylazine and increase of xylazine. There's also been a lot of push to have mobile wound care for people to really go to where folks are at to provide support, wound care kits, a lot of messaging and dissemination. So I think there's been a lot of great stuff. We do have a little bit of drug checking, except this is thus far been tied to research projects, which is a huge limitation for longevity. So I do know that's something that folks are, working to launch here, really kind of in tandem with the Overdose Prevention Center. So I think there's a lot of great progress happening. Of course, we still need to, there's ongoing fights to also really get at these root drivers. So, housing inequities and really supporting people across the care continuum and meeting people's basic needs. So a lot of advocacy, a lot of good progress, but still a lot more to go.
Great. And I know that time budgeting has not been excellent, and we have about 8 minutes left for Q&A. But the first question is for Louise. And it is, can you expound upon the drug user hierarchy and what can clinicians do to improve their drug user cultural competency?
I think any way we can create community among everyone. I see a lot of these drug user health hubs or SSPs, whatever you're calling them, are delivery service only. especially here in North Carolina, we really need to have a place to come for community, like a place where drug users like their own like rec center, which is what we're basically trying to, we're building a small model and building it out. But I think anytime you can create community among everybody, and so everybody's just in a space together, it reduces those lines, because people may not naturally hang out together, but if they're naturally hanging out together at the drug user health hub using the wound room or whatever. And I wanted to mention the wound room because Alex was good enough to mention wound care. And I just wanted to throw that in there, that North Carolina Survivors Union is really driving a some work around a wound room, because if you are homeless or houseless and you don't have or your house is just not really clean, these xylazine wounds can be this big, they can be this long. And so we're trying to create a space where people can do that for themselves. So thanks.
I would also say that I think this entire session has really highlighted how important it is to have a national drug user network where we can disseminate information quickly about changes in communities that are, will eventually come to other communities. And I think to tag on to that, I think it's really important for clinicians to be connected to those national drug user networks. And I've got a question here. What is the amount of use of these drugs in the suburbs? Also, what is the overdose rate, or do we not have that information as they may have private insurance? I don't know whether anyone wants to address the use of new synthetic drugs in suburban communities, but also if anybody else has a response around the drug user hierarchy and the drug user cultural competency question, I'd welcome that as well.
I think that a lot of the stuff about like in the suburbs and all of this, if there, so the question is like, it seems to be a disconnect. Yeah, but let me pull it back up. I'm sorry. Uh, what is the amount of these drugs in the suburbs? I would say that, it used to be that drug use systemically was kind of like in different places, hot spots, stuff like that. Well, now it's everywhere. Now it's everywhere, and I hate to say this, but like that's why the big push is a whole bunch of white drug users died. Black and brown drug users have been dying by this for a while, and as soon as a whole bunch of white drug users started dying, we started looking at this, and I mean, the idea of saying like, what is the amount of use of these drugs in suburbs is I understand why you're asking it, and I get it, but it's just not something you can answer that effectively if we're not doing the other side of it. Does that make sense?
Yeah, Edwin, go ahead.
Yes, in the Washington, D.C. area, we've had a lot of media attention paid to overdoses in suburban schools. And I think when we look back at the fact that these drugs are, particularly fentanyl, mixed with others, that in many instances there might be young people using marijuana that's tainted with fentanyl. And now with this switch to smoking, and of course using these vape apparatus, that you can see how a young person could easily accidentally overdose in unintentionally in that arena, and we see this a lot in bathrooms in our suburban schools. We actually had a quadrupling of overdose deaths in the District of Columbia in young people under the age of 19. So we went from 3 deaths to 12 deaths in 2023. So I think that when we look at this constellation of legalizing marijuana, that we're going to unfortunately see an uptick in these accidents.
Any other comments on either the question on drug user hierarchy and drug user cultural competency and what clinicians can do to improve it, or the rate of use in suburbs. There's also a question here, and perhaps we can have one person answer it in the next 3 minutes, around community engaged methodology to address the issues we raised during this session and understand drug user behavior. What are good ways to connect and collaborate with people who use drugs in a way that they're driving the research study questions and approaches. I think we've discussed this in other seminar sessions, but if anyone has a quick response, I would say to just keep on initiating long-term relationships with community organizations so that you're not pulling them in when a desirable RFA comes through, but that you have time to brainstorm together and create research questions together based on a long-term sustainable relationship, is my 2-second response to that. Does anybody else have one?
I might just add to Katie's point of like, this is an issue that's impacting communities, and as researchers, you need to bring money. You need to budget in money. You need to bring money for the organizations doing the work, money for the people who are doing the caretaking, money for the folks living this and surviving this, and follow their lead and very much, follow what community is saying that they need. Be a conduit, not an expert. So that's my only other 2 cents.
Yeah, I would just underscore what you said, Katie, about have these relationships existing. I mean, you should have research questions already ready for any RFA if you've got a group of drug users and that's interested. And I'm going to tell you, it changes lives to have people feel like they're engaged in the political system, to feel like people are engaged in systems of change. Even when we go out and protest and we don't change anything, that it builds something. You're part of something. You're part of community. I mean, being part of harm reduction, I've said this once already, and being part of a community has saved my life and the lives of almost everyone I love. So I just want to underscore that as being a real lifesaver. We need to feel a part of something as humans, and especially drug users that have been tossed aside or told they're worthless and shown they're worthless. And it really does something.
And much as we like to pretend it isn't, the research process is inherently part of the political process. Thank you for bringing that point about compensation up. We are at time, but Edwin, please go ahead.
Yes, so just one last comment. When I was growing up, we only had 3 TV stations. They all went off at 11 o'clock. They were censored. We now have public media, and we really have to be cognizant as parents and grandparents of the messages that young people are getting through music and social media. So if those messages are about using drugs and guns, then those are the messages that our young people are going to be infiltrated with, and it's happening. So we really have to change what we in Washington call the message in the music. It has to be positive and clean.
Thank you for that, Edwin, and thank you for bearing with us while we went 1 minute over time. Thank you so much to all the panelists for this dynamic discussion, and thank you so much to our audience for absorbing it, and have an amazing day, everybody.
Thank you.